everybody, it's Dr. Julie Sarton, and after 30 years as a pelvic floor physical therapist, the biggest mistake I see clinicians make is treating the pelvic floor in isolation, especially when it comes to patients with IBS, particularly IBS type C, which translates to constipation. So I want you to remember that IBS doesn't just live alone in the gut, rather it changes how your pelvic floor functions. So in this video, I am going to teach you how to identify when IBS is actually driving your patient's pelvic floor dysfunction and what to do about it so your treatments actually work and you get your patients better faster. So let me give you an example of a patient that we see every single week in our clinic. This is a woman who walks in who complains of pain with sex. She has been to another clinic, had some pelvic floor therapy, internal vaginal work done. She's learned how to use dilators to self-treat her pelvic floor, and she's done all the stretches, yet her pain persists. Why is this? Perhaps it's because no one bothered to ask about her bowel habits or evaluate her gut. So besides her painful sex, she's constipated. She's having a bowel movement once every 5 to 6 days. She's straining. She's bloated. She's got some GI discomfort and pain. But if we don't ask about it, we don't know. This becomes an underlying driver for the pelvic floor to become overly active, at rest, have a chronic cycle of hypertonicity, which will return even if the pelvic floor is released. So if her treatment keeps failing, it's not because the pelvic PT is wrong, it's because the PT didn't address the true root causes and look at all the underlying systems for the patient that results in pelvic floor dysfunction. So where do we start when we screen for IBS-driven pelvic floor dysfunction? Before we get started, go hit the subscribe button. That way, if you leave me a question or a comment, I'll see it. And I really want to answer it to help you with your patients. Let's get started. Ask the right questions. Number 1, how often do they poop? Number 2, what does their poop actually look like? Have a chart called the Bristol Stool Scale available so they can look and tell you. Number 3, do they strain? What mechanics are they using to eliminate? Do they feel like they've completely emptied after they eliminate? Number 5, do they have any pain associated with defecation or afterwards? Number 6, is there any history of any type of fall onto their tailbone or low back, sacrum, or hip, even if it was years ago? And we'll come back to that later in this video. So next step, you need to look at their belly. Yes, that is going to require you to lift up their shirt so you can see what the abdominal wall fascia looks like. Are they bloated? Is there evidence for inflammation present? We will see changes in the fascia, which will resemble kind of a lumpy, gunky look through the abdomen that a lot of people just think is really fat or cellulite, but truly is due to fascial restriction, as the collagen and elastin fibers change in response to an inflammatory driver such as IBS. You can refer to some of our older videos on how to then go and treat this with a technique called connective tissue mobilization or skin rolling. This will reverse this process and drop the inflammation all through the gut. Now, an aha moment I want you to remember is that if the fascia through the abdominal wall has changed, it is continuous with the pelvic floor fascia. So as we go down into the pelvis, that fascia will stay irritated if we don't restore healthy fascia up through the abdomen around the gut. Now, if this goes unchecked for a long time, maybe years, it's been their whole life, they've been constipated, there will be something that can develop called visceral hypersensitivity. And this is when the organs become hypersensitive to changes in pressure, for example, like gas or bloating. And remember, fascia itself has 6 to 10 more sensory nerve endings than muscle. So it makes this soft tissue structure so much more part of the pelvic pain puzzle and absolutely needs to be addressed. So that leads us next to what is happening to my patient's intra-abdominal pressure. Why does this matter? Well, the diaphragm, which is our main breathing muscle, and the pelvic floor, they have a huge pressure relationship. So when the diaphragm can descend nicely, then the pelvic floor can drop, and vice versa. When the diaphragm ascends, the pelvic floor follows that. So if there's abnormal straining due to to constipation, if there's abnormal breath holding, either due to anxiety or with a heavy weightlifting program where people breath hold to lift, then there will be a problem with the intra-abdominal pressures coming down and influencing the pelvic floor. Ask about biomechanics, but then go back and ask about exercise. One more question for you to connect these dots. Next, look at your patient's breathing mechanics. So that diaphragm we just talked about, if it can't descend, perhaps because it's super restricted due to fascial changes or muscle spasm, then you can teach diaphragmatic breathing until the cows come home, but your patient can't achieve a change. And that diaphragm shouldn't just drop, but it should expand three-dimensionally. So when it does come to breath work, I want you to think and assess what's happening laterally and even through the back, because that diaphragm should be able to move three-dimensionally as well as the breath. If you find that that diaphragm is indeed restricted, there are manual techniques that you can use to help release that. So refer to our prior videos that demonstrate a diaphragm release technique that you use with your hands to help achieve a healthier state, allowing for that 3D expansion. Lastly, let's go back to that question we asked in the beginning. Do you have any history of falls, even if it was early in your childhood? Why are we asking that? Because the tailbone has an intimate relationship with the pelvic floor muscles. The deep pelvic floor attaches to the tailbone. Now, if they have had a fall and they didn't necessarily even fracture, but they had enough force that changed the position of the tailbone and pushed it into what we call a flexed position, where it's hooked under. The distance that the pelvic floor travels from the front of the pubic bone all the way to the back where the tailbone is will be decreased. And so that changes the resting state of the pelvic floor. It also makes it a little bit harder then for the pelvic floor to elongate, which needs to happen so that you can get a full release around the external anal sphincter and the anal canal can open beautifully and we can release and get full evacuation. So if you find as a pelvic therapist, PT or OT, that this is an issue, please refer to some of our other videos on how to treat that tailbone that's either hyperflexed or pulled off to the side, which is lateral deviation, or rotated. So end of the day, if your pelvic pain patient or patient who is experiencing pain with sex is not progressing, please remember IBS pelvic connection. Ask the right questions, screen appropriately both the abdomen, the pelvis, the pelvic floor itself, and position of the bony structure, especially the coccyx, and you will be able to move the needle with your patients, again, getting them better and going after a full multi-body systems approach. So our takeaway today is to realize IBS isn't just a gut diagnosis, it is a pelvic floor muscle disruptor. Pelvic cheers.